for a Healthy Future, and I want to welcome you to the Strong Foundations event this morning. For those of you who are new to Georgians for a Healthy Future, we're a consumer health advocacy and policy organization, and we really work towards a day when all Georgians have access to the quality, affordable health care they need to live healthy lives and also to contribute to the health of their communities. And of course, children's behavioral health is a big part of that, and as a new and timely issue, we think it's really important to help educate our partners, many of you in the room, a lot of our stakeholders, consumers, those who are tuning in on the web today, about this important issue, and especially during Children's Mental Health Month. It's a nice time to sit down and examine what's happening here in Georgia. Before we get started this morning, I do want to acknowledge a couple of people in the room. First off, one of our board members is here today. Banny, if you could just give a wave. Banny Lassane is one of our board members. Our staff has worked really hard on this event, and so I'd want to introduce them really as well. And so this is Alyssa Green, our Outreach and Education Manager. And then Michelle Condi, our Communications and Special Projects Manager, was at the reception desk. I think there she is. Hi. Sorry, I thought you were still back there. And then we also have two wonderful interns that have worked for GHF this semester and will continue through the summer. Jessica Swinarski was at the desk and I think still is, as well as Nilüfer Shalampat, and she was graduating from Emory yesterday, so she's with her family today, so she's not here with us, but has helped out quite a bit. And then I also want to thank Michelle's brother Louis for his voluntold service this morning, also at the check-in desk, so it's nice to have him, his help as well. And then finally, we really appreciate the support of the Department of Behavioral Health and Developmental Disabilities. We've really been able to dive into the work of children's behavioral health with their support, including the development of this new fact sheet that's in your folders. And then also a forthcoming policy paper, which we're looking to release this summer, so keep an eye out for that. Thank you to all of those folks that I just mentioned. And I want to give you guys just a quick idea. I think I'm pressing the wrong button. There we go. Of what we're going to do, what's going to happen this morning. So first, we're going to hear from a consumer, Miss Tammy Harrison, who is a person in recovery and has navigated the behavioral health system to kind of help ground us in what real Georgians are experiencing when we talk about behavioral health. Then I'm going to do a very brief presentation just to kind of provide a lay of the land, make sure that we have some shared understanding about really what we're talking about when we discuss behavioral health for youth here in Georgia. Then we're going to hear from Dante McKay of the Office of Children, Young Adults, and Families out of the Department of Behavioral Health and Developmental Disabilities. And then we'll take a very brief break, and we'll be back with a provider or a panel of behavioral health service providers, and they're going to really discuss what the system of care looks like in operation and how they serve Georgia's children. And then we'll send you guys home with a boxed lunch right before noon. So I want to welcome up Miss Tammy Harrison. There you go. Here you are. Welcome. And she's going to just share with us her experience and what it's been like.
Good morning. My name is Tammy Harrison, and I'm going to be sharing my story, which is called Walking in My Purpose. I was born in Hamilton, Ohio, which is a small town outside of Cincinnati, Ohio. And those were the good old days. Everybody kind of knew everybody, and I was able to build a good solid foundation with my family. I had my grandmother, who was one of those people who cooked everything from scratch. She made homemade cakes and cookies, and every day when I went home from school, I would go across the street and I'd say, "Grandma, what you got good for me?" And she would always have something nicely baked. And she was a God-fearing woman who believed in prayer. Every day she would pray every morning and every night. She had 10 children. And my grandfather was one of those community people. He had a community garden. And so, he would share his garden with people in the community. And so he was a person who kept everybody together. My family was very close-knit, big family, and I knew my aunts, uncles, cousins, and so forth. And then about when I was about 8, we moved to California. My mom and my stepdad moved to Northern California because of my stepdad's career goals. And so from that day, moving from a small town into a big city was a culture shock for me and my family. Shortly after we moved there, my mom got some really bad news that her youngest brother of 10, had died in the Vietnam War. And she took it pretty hard because she wasn't able to travel back for the funeral, which made it kind of difficult for her. She suffered with depression. She started using drugs and ended up telling me, you know what, we're going to leave this place. And when we leave, I'm going to have to put you guys in a foster care system. And I'm next to the oldest out of 6. So that was pretty tough for us. In San Francisco, they had a shelter that it was a place where they held you until they found a placement. And way back then, my mom was already doing advocacy work. She knew she had to do an 18-month residential treatment program at Napa State Hospital. And so she started advocating, letting them know that she wanted us to all be placed together. And so we ended up being placed together in Vallejo, California with the minister and his wife. Things were going really good. We were doing our visitations. She was working her program. And shortly after we moved into the foster placement, my foster parents' nephew came to stay with us. And he was an older young man. And he actually started torturing me and my siblings. He would do things like hang my younger brother, who was 2, up on the door ledge and just let him hang there until he couldn't hold on anymore. Hang him out the window. And he also was touching me and my sister inappropriately. So when I got a chance to visit my mom for visitation, I told her what was going on. And immediately, being the person she was, she advocated for him to be taken out of the home or for them to move us to another placement. Consequently, they moved him out of the home, and she completed her 18-month program, worked her program. She had a case plan. She had to find a job, find a place for us to live, and various other things she had to do in order to close her placement. And so we ended up getting placed back at home with my mom. She ended up getting a job for the school system working at a daycare center. So it was kind of convenient because when we left home together. So she take my younger siblings to daycare where she worked, and we went to the elementary school as well. So we went home together. We went to school together in the mornings, and in the evenings we would go there after, and then we would go home together. My mom quickly registered herself for school. She went to school at Cal State Hayward. She graduated with a licensed clinical social worker degree and ended up working for a residential treatment program because that was her background. She also had background in nursing. So it was really good at that time because then she was able to buy a home, which grounded us. We were in the same home for like 27 years. I was able to graduate from high school. We had a really good support system, me and my mom. We were more like siblings than mom and daughter because a lot of things that she went through, I went through with her. And she shared a lot of things with me because we were close. And so consequently, when I got ready to go to school, after I graduated, got married, I went to college, and she was my biggest support system. And so one of the things I realized quickly was it was about relationships with people, with my parents, with my family. And I ended up, after I got married, I had 2 sons, and consequently, both of my sons had diagnosis too. So it kind of transitioned me into learning how to advocate for them too, for services as well. So I spent a lot of time in the schools because they had behavioral issues. My oldest son, who's 32 now, he had was diagnosed with a learning disability as well as dyslexia and ADHD. So he had a lot of problems in school, which kept me going up to the school. So rather than have a regular job like other people, because I was being called almost every day, I ended up getting volunteering a lot at the school and then getting a job at working with the school system, which kind of launched my career after I graduated, just having jobs working with the school system. In California, I worked with the school system with other families who were raising children that had a disability, as well as transferred to Decatur, Georgia in 2003, and I ended up working for City Schools of Decatur and working with the Exceptional Student Services Program, and worked with them for about 4 years till my oldest son graduated, and then I ended up working with GFACS, working with one of the first pilot programs for parent partners who are parents that have raised children that have a disability to support other parents. So that kind of launched off my career with really just working with parents, working with them around how to access services, get services in the community, and so forth. Then I left there and worked with the CAP Community Service Board for a couple of years. It was a program for people first psychosis diagnosed, and they were young people, and just really working with those families and trying to help them identify resources in the community and so forth. Currently, though, I just started my own nonprofit about a year ago called DeKalb Families in Action, Inc. We're located in Stone Mountain, Georgia. And I really just say walking in my purpose, because I feel like all of the things that I went through growing up, through my adulthood, and now really focuses on the things that I went through kind of really help with what I'm doing right now. So I really enjoy the work that I'm doing. I have several mini contracts that I'm working on. I've been in the GNET system, and I can really see how parents really still need support from other parents who have kind of navigated through multiple different systems and learned how to really work with the professionals to make sure that they get quality service for their children. And so I'm really excited to be here today. I'm a little bit nervous, but I wanted to know if anybody had any questions. Great. Thank you so much.
Thank you. It's such a pleasure to have you. Thank you, Tammy. I appreciate you taking time out of your day and joining us this morning. One more round of applause for Ms. Harrison. Great. So as I mentioned, I'm going to provide kind of a quick lay of the land for all of you. And before we get started with that, I want to just ask by a show of hands kind of who feels like they have some expertise or experience with behavioral health already, kind of in this work. So we've got some, but not a lot. And from the GHF perspective, we felt pretty similarly. We've been doing work in substance use prevention for a number of years now, through a strong partnership with the Georgia Council on Substance Abuse. But really, it's been in the last 2 years that we've dived into this work around children's behavioral health explicitly, and doing a lot of research and getting to know the behavioral health system. And I will tell you, the more I get to know it, the more humble I am about how little I know about it. So I thought, for that reason, that it would be good to help us all kind of define some terms, have some shared understanding, some shared language before we hear from our later speakers, so that we can really benefit from what they share with us. And I'm hoping that, along with you all, that we do some learning from many of you in the room as well, those of you who do have expertise and practice in this area. And I know for some of you guys over here, the slides are a bit tricky to see, so feel free to come on over if you need to. So first, I just wanted to define behavioral health, and this is something, as I talk about my work in the public, whether it's with friends and family or at formal outreach events, we get this question a lot: what is behavioral health? And so I did want to start there today, and just acknowledge that behavioral health is more than just mental health. It includes substance use behaviors as well as co-occurring disorders, and that there's quite a broad spectrum when we we talk about mental health or mental illness, that it can stretch anywhere from attention hyperactive disorder to severe psychosis, and anywhere in between. And so just understanding that behavioral health is an umbrella that includes a lot of different conditions and a lot of different collections of symptoms that may not be diagnosed or that may not be named and identified at all times. I also wanted to acknowledge that childhood and adolescence are really key time periods when we're thinking about behavioral health. So about half of behavioral health conditions emerge or begin before the age of 14 and 75% before the age of 24. And so during Children's Mental Health Month, this month is so important because that time period is so critical in the prevention and early intervention around behavioral health. And also, as with many diseases, cancer, diabetes, HIV, behavioral health is much more treatable in the early stages, so that whether we can prevent it or intervene at the earliest stages possible, that's best because it's easier to treat then, and it's easier to make sure that people can get to a place of recovery and have a normal, healthy life. And then also I just wanted to mention that often when we think about childhood and adolescence, there's a lot of transition and can be a lot of stress during those times. And so often that's when behavioral health conditions emerge. So we see them emerge sometimes in that transition between high school and college. So sometimes young adults will experience their first kind of psychotic episode during that kind of first semester or year at school away from home, or as a child may be transitioning from one home setting to another, we may see the onset of some kind of behavioral health disorder. And so those periods in a child or young person's life are really critical to this as well. And so I wanted to provide kind of an idea of the scope of behavioral health issues in the country, and then in the next slide in Georgia. So you can see here that behavioral health conditions are not uncommon. Almost half of the U.S. youth have some kind of behavioral health condition throughout their childhood. And within any 10-month span, about 13% of youth are experiencing a behavioral health condition. You can see that co-occurring disorders are more rare, so about 1.4 or 1.5% of your older teens, so 12 to 17, are experiencing co-occurring disorders, but it's still a pretty significant number and something that we need to think about as we're thinking about the system of care. And among Georgia youth, so these numbers, about 9.5% of Georgia youth have a diagnosed behavioral health condition. Remember when I was talking about kind of what behavioral health is, it's not always diagnosed. And so these are the children ages 2 to 17 that have a diagnosed behavioral health condition, and certainly there are more that have not been identified. But of those that have been diagnosed, about 44% of those have more than one diagnosed condition. So, we looked at those co-occurring numbers in the previous slide, but once you've been diagnosed, the co-occurring disorders become more common. And then behavioral health conditions do become more prevalent as youth get older. Again, when we think about those times of transition and stress, accumulated trauma, your prevalence goes up from that 9.5% to that 14.1% that you see here. And so when we think about those percentages, what kind of behavioral health conditions are we really thinking about? And these are the most common, both mental health conditions and then among substance use. And on mental health conditions, you can see here that anxiety and depression account for the highest number of mental health conditions among Georgia teens who are ages 13 to 18. And then attention hyperactive disorder under that. Again, these are not the only, but they are certainly the most common. And then for substance use, we're really looking at marijuana, followed by tobacco products, not just cigarettes, but all tobacco products and nicotine delivery devices. And then also binge alcohol. I think most of the time, as an adult, I think about alcohol more than ahead of the others. And so I was a little surprised to see some of these numbers here. So, when we talk about other health conditions, so when we think about cancer or diabetes, for example, we usually talk about kind of what are the factors that contribute to whether a person develops these diseases, what are the risk factors and contributors, and so I wanted to talk about that a little bit this morning too. And so, obviously, just like with other physical health conditions, there are multi-factors that contribute to a person's behavioral health, and those include biological factors, which are your genetic makeup, things like that, psychological factors, which are self-esteem, coping skills, chronic stress, and then social. And I'm going to focus on social primarily this morning, first because I don't have a PhD in this area, and second because as a policy organization, the social factors are really where we can make the most difference, and they're the most susceptible to policy intervention. And so as we're thinking about the system of care and what the advocates in this room can do, and what those of us who practice behavioral health as a profession can do, that social piece is really where most of us can make the biggest difference. And so I want to spend a little time on that this morning, starting with the social determinants of health. And I think most of the folks in this room are probably pretty familiar with the social determinants, but for those who aren't, these are really kind of the circumstances in which people live and work and grow. And also the systems that support health care and health services. And so these social determinants are really strong indicators of strong factors that contribute to a person's health. So having poor social determinants can increase your risk for having poor health outcomes, physical and behavioral. And so I've included here a quick list of some of the primary social determinants of health. And at GHF, we spend a lot of time thinking about the access to care piece. But we are starting to do some work around some of these other pieces, access to education, unemployment and job security, income inequality. Housing is something we've spent a lot of time thinking and reading about and are hoping to do some work in. And this morning we'll talk also about the adverse childhood experiences piece, what's commonly called ACEs. And so I wanted to provide an example of kind of how the social determinants of health may impact a person's likelihood for a behavioral health outcome or poor behavioral health. And here you can see that, so income is one of the social determinants that we spend a lot of time researching and thinking about. And so here you can see that children in Georgia who live in households below the poverty line, so that's about $20,000 for a family of three, about 13.6 of them have a diagnosed behavioral health disorder. And then for children who live just above that, so 100 to 200% of the federal poverty line, so about $20,000 to $40,000 for a family of three, only about 9.2% of those children have a diagnosed behavioral health disorder. So you can see here kind of how the social determinants of health start to contribute early to diagnoses and to health outcomes. And so I mentioned that I wanted to talk a little bit about adverse childhood experiences, and some of you in the room can probably speak more knowledgeably about ACEs than I can. But as a quick introduction for those of you who are also new to the area, an ACE, an adverse childhood experience, is really a traumatic event that occurs in a person's life before they hit the age of 18, and that they remember or somehow contributes to their behavioral health in the future. And so, and it's a pretty major risk factor for behavioral health outcomes. And so when we look at children in Georgia, about half of our kids don't have any adverse childhood experiences. But about a quarter of them have one, and then another quarter of them have two or more. And that's not just two, that's two or more. So we could be looking at, some children with 3, 4, and even higher than that. And again, as an example of how this contributes to behavioral health outcomes, there are disparities among adverse childhood experiences among Georgia kids by race. And so here you can see that here in Georgia, about 41.5% of Georgia kids who are white have at least one ACE. And then it goes up from there. So 53% of Latino children in Georgia have experienced an adverse childhood event, and 57% of Black children. And so as we think about the system of care, these are some things we want to keep in mind, and how are we supporting children who have higher risk factors for behavioral health outcomes, and how are we addressing disparities as we build and support the system of care. And then finally, I wanted to talk a little bit about how children access behavioral services in the state. And we're going to hear a lot more from the providers in the room at the panel later this morning. But I just wanted to provide a very brief overview. And for GHF, we spend a lot of, historically, we've done a lot of work around health coverage and health insurance. And so it was helpful for me to kind of break up how people or how children get behavioral health services based on their coverage type. And so you'll see this on the back of your fact sheet, kind of a bigger, more complete version. And for those of you on the webcast, we will send out this fact sheet afterwards so you guys have access to it. Or Michelle, I think we linked to it in yesterday's email, so you have access to it already. So children access behavioral health services depending on their coverage type. And so for kids who are covered by Medicaid or a CMO Medicaid, so a care management organization, so if you're in the traditional Georgia Families Medicaid, or you're covered by Georgia Families 360, which is children in the foster care system, they access behavioral health through the CMO's provider directory, and that's paid for through Medicaid. And you can see here, then today we're really gonna focus most heavily on this blue line, children with disabilities who are covered by SSI Medicaid, and then children who are uninsured. And they access behavioral health services through DBHDD's provider network, and those services are paid for by DBHDD and Medicaid. And then for children who are covered by Peach Care for Kids, it looks a lot like those who are covered by the traditional Medicaid. So they access it through their CMO provider directory. And then for children who have private health insurance, they go through their insurer's provider network, and it's paid for by that private health insurance company. But this was just helpful for me to understand kind of when we think about policy interventions and public policy decisions about the different systems that impact the behavioral health system, which bucket or which kinds of kids, which group of kids are we really impacting when those decisions are made, or when system changes are made. And again, as we think about the system of care, we may see children move through these different categories throughout their development. So they may be born and they might be covered by private insurance, and as they grow up, they may end up covered by Medicaid at some point, and then kind of hop back and forth between some categories. So having a robust system of care across all of these systems is going to be very important, and thinking about what influences each system or each payer type in each system is also going to be an important consideration as we think about how to best support kids across the state and across payer types. So I'm going to leave it there, but I hope that gives you guys some foundational background context for the rest of the discussion today. I am happy to take some questions. Alyssa, do I have time for questions? Yeah, good, great. Yes. Yeah.
One of the issues around that is that it has to be if the person as an adult either remembers it or views their experience. I actually think that number is way higher. Because if you look at the factors that become an adverse childhood experience, it's living in poverty, it could be having a single parent, it could be substance abuse in the family or mental health issues in the family.
Mm-hmm.
It's so much more prevalent, and the impacts are far more costly because of trauma than we may have realized. And I just don't want people to think, well, we're doing pretty good because half of our kids don't seem to have them.
Yeah.
It's just a little misleading how to, be interpreted.
I think those are great points. So for the benefit of our webcast folks and anybody else who didn't quite catch all of that, there's just some thought around, how we define ACEs, and it's very possible that the number of kids who have experienced adverse childhood experiences is much higher than this half of a percent or of the population, and that we should keep that in mind as we're thinking about how to best address behavioral health needs in Georgia. And I agree. I think that this definition, and as I mentioned earlier, I'm still learning, and so this definition is definitely, I think, a bit limiting because it does require that somebody remembers the experience, and so I think that there are a lot of instances where they don't necessarily recall it concretely, and it's still impacting them. Yeah, it's internalized in some way. I think that's a great point. Any other questions? Yes, Ms. Hawkins.
How do you think Georgia compares to other states when it comes to these proportions that you have on the fact sheet?
So the question is, how does Georgia compare based on kind of some of these statistics? I don't know right off the bat. I should have pulled some numbers yesterday. I know that our access to care ranking is pretty low as compared to other states. The prevalence numbers, I'm not sure. I know that that the prevalence rate for, I'm going to have to go back and look at my slides, that behavioral health conditions become more prevalent as kids get older. That mirrors national trends, so we're not out of step there. But we certainly have some work to do around access to care, and that's why I think it's important to look at all the different systems, because there's certainly areas for improvement in all of the different pathways to services. Thank you. Great question. Yes, Brian. Yeah, so that is on your fact sheet. So I'm going to flip back there for a second. So for those of you who don't have your fact sheet right in front of you, those who access services through the Green Line, through DCH and Medicaid, that's about 39, almost 40% of Georgia's kids. And through the blue DBHGD pathways, that's about 8% of Georgia's kids. Again, that's especially when during Dante's presentation, those are kind of the group of kids that we're thinking about during that. This purple line through CHIP is about 5%, and then most of the children in the state are covered by private health insurance, and that's about 45%. And that's broken up between both employer-sponsored health care, health insurance, and then individual plans. And again, as we think about policy interventions, for those who are covered by employer-sponsored health insurance, the state has very little control over that. It's overseen at the federal level. And so really as a state, we have the most leverage to make change within these top three. And then for some kids who are covered by individual plans, individual private plans, we have a lot of leeway there as well. So we're really thinking about kind of the top three make up about half of Georgia's kids collectively. And so we're thinking about those children when we think about kind of state level policy decisions. Jewel.
Also, just to note, I didn't really see it in your slides, but when we're talking about those who actually have diagnosis, half of those do not actually seek treatment. So that's another, we're talking about access to care, being able to identify what are some of those additional factors that prevent children and their families, of course, to be able to go to treatment, to receive the treatment they deserve, that they actually need in order to be more functional. I think from a policy standpoint, I'm trying to figure out how to reduce some of that stigma associated with mental illness, and or substance use disorders as well too. And then looking at the disparities of that populations as you look at Caucasians versus African Americans, and how much is that of having access to like brick You have less facilities that you can have access to depending on what your insurance is and what is available, and more education of parents too. So I just thought that was also important.
Yeah, so I think that is a good note. So even among the children who have diagnoses, again, for those on the webcast, about half of them don't seek treatment. And certainly I think there are, coming from a public health background and being more familiar kind of with work around HIV, there's that HIV treatment cascade that some of you will be familiar with. So those who are HIV positive, and then it steps down, and people who are actually diagnosed, and then it steps down again, and then there's the percent who actually get into treatment, and then it steps down, and those who have a viral load suppression, which is ultimately where you want to get to. And I imagine there's that same cascade effect among children with behavioral health needs. So there's those who have some need, and those who are diagnosed, and then those who get treatment, and then those who get to a place where they can function healthfully and within and do their activities of daily living. So we do want to identify barriers, I think, at each step along the way, and I'm hoping that today's conversation can help with that a little bit. Mr. Mancini.
Thank you so much. Good morning. The comment I would make is that we also have this group of kids who have parents with limited English proficiency, and we don't really have the infrastructure for those parents to be able to access even if the service is available, and which is very limited in that area.
Yeah, and I think you make a great point about culturally competent and linguistically competent care. So for the children whose families are not native English speakers, how do we make sure that they're getting the care they need? I think that's a great conversation. I know that at the at Georgia Budget and Policies conference this January, they had a great conversation with the Center for Pan-Asian Community Services about that very issue and about how do we build a culturally competent workforce. And I know that Erica Fenner-Sitkoff is here from Voices for Georgia's Children. She's going to moderate the panel later. And they did a wonderful workforce analysis piece. And I think that that's part of some workforce development conversations, is how do we make sure that we're building a workforce that really meets the full needs of Georgia kids, not just those who are native English speakers or those with a certain cultural background. Yes, ma'am. Mm-hmm. Yeah, so a great note about making sure that we're cognizant of the full spectrum of services, and not just therapy or medication or kind of those healthcare type services, and more thinking about the supports, parent education, advocacy, those kinds of services and supports. And I think that's very important. And again, hoping that some of our providers can speak to that later this morning. So I think this is a great kickoff to the discussion. It sounds like a lot of you in the room have a lot of great thoughts and knowledge about the system of care. And again, I'm very excited to do some learning with you this morning. And so what I'm going to do is bring up Mr. Dante McKay from the Division of Behavioral Health, Office of Children, Young Adults, and Families. I think I got all of that right. Within the Department of DBHDD. And Dante is the director of that office, and previously state director at Enroll America, and before that Voices for Georgia's Children. So he's very familiar with Georgia and our needs and our landscape. And so we'll hand it over to you.
Thank you.
Thank you.
So, good morning. Again, I'm Dante McKay, Director of the Office of Children, Young Adults, and Families at the Department of Behavioral Health and Developmental Disabilities, DBHDD for short. and in the behavioral health division. And so, apologies in advance. I'm going to toggle between two devices because my eyes are not that good to be able to read from there. But a couple of things about me prior to. I'm so happy to have Georgians for a Healthy Future delving into children's behavioral health. It's a well-respected statewide organization with a broad followers, and to have them take a look as it relates to whole health, looking at both physical and behavioral health. I'm just really pleased about that. And so a fun fact, previously served as the director of health policy at Voices for Georgia's Children. At the time, I was out of state. And so my first interview was via telephone, and the second interview was in person by the time I had relocated back in the state. I use Georgians for a Healthy Future, their website and their materials to study for that job that I landed. So it comes back full circle. I'm also a son of a parent that lived with a severe and persistent mental illness. My dad was a Vietnam era veteran, and very early on found myself being his advocate. So I have lived experience as a child and a family member, and really that advocating on his behalf for the first part of my life led for me to pursue first going to law school and getting a degree in public administration, and again it came back full circle. And so I had some of the skill set that the department was looking for, but I think having that lived experience, which I talked about a lot during that interview, helped to land me at the department. So I'm glad to be with you here today, and we'll dive into the slides here. So I want to talk to you about four things today. So the public health system service array. And so basically my office and our role in the system. I'll talk about the system of care framework, both the federal framework and how it came to be in Georgia, what it looks like in Georgia. I'll talk about the Georgia System of Care State Plan, just a very high level overview. And then I'll talk about the Commission on Children's Mental Health recommendations and provide some updates there. So first, yeah. So this slide reflects bell curve and the public system, mental health system service array. And so DBHDD is the Behavioral Health Authority, but we are not there are many organizations and state agencies that also have a role in the system. As Laura mentioned, our focus is on children that are uninsured or have SSI Medicaid, which is a very small percentage of the children in state overall. But what this slide shows is the continuum of care. So in addition to supporting programming, non-traditional programming and supports that complements the Medicaid service array, we also look to maximize our state dollars and federal dollars by investing in infrastructure-related things that would allow providers to bill for Medicaid services, in some cases private insurance. And then that small percentage that is uninsured or has SSI Medicaid, our funds will cover those services. So what you see here is a bell curve that covers early screening through late intervention. And so reading right to left, Project Launch is a partnership with Department of Public Health. The Department of Public Health received a SAMHSA grant. It's a 5-year pilot that really looks at coordinating services for children, both physical and mental health, ages 0 to 8 in Muskogee County. And so what's different there is that the ages that we focus on from our office is age 4 through 26. That matches the state Medicaid plan. And our partners in public health take a look and decal from 0 to age 3. Well, this pilot and for Project Launch allows that work to go up to age 8. And you may hear a little bit more about that pretty soon here. So then continuing to move over to the right, that CIP stands for Community Innovation Pilots. And essentially what that does is allow us to invest in opportunities that will complement and shine light on the public mental health system, as well as others that may need to know this. It helps to increase awareness. It helps to conduct some research. It looks at innovative ways to better behavioral health services and treatments in the state. Also, in that early intervention range, the APEX program is our school-based mental health program. It's 3 years old. We started at the end of year one, we ended in 136 schools. We're currently up to 320 schools. I'll talk a little bit more about that as it relates to the commission recommendations. Thank you. Youth clubhouses. We operate mental health clubhouses within the state. There are 3 types, however, and what I didn't include in this slide is there are in the behavioral health division there are 9 offices, and all 9 touch our population in some way, and so that clubhouse is plural. We have prevention clubhouses that are supported by our Office of Prevention. We have substance use clubhouses that are supported by our addicted disease office. And then for my office, we have mental health clubhouses. And then we have a couple of pilot clubhouses that are co-occurring that serve youth and families that have co-occurring mental health substance use conditions. Moving right, system of care and emerging adult support services are programs that we support. That CPS and Y stands for Certified Peer Support Parent and Certified Peer Support Youth. Georgia has a long history in working with peers and supporting peer programming as national leader, and basically that allows us to be able to tap into the lived experience that really helps individuals along their journey. So it's someone that has been in their shoes and takes them by the hand and helps them on the road to recovery and resiliency. And so that is a service that was that particular one recently added to our state Medicaid plan, and which allows providers to hire these individuals and bill Medicaid, so thus they have a payer source to be able to provide that service to individuals and families that need it. At the very top is LIPT, Local Interagency Planning Teams. I'll say more about that shortly. Moving over, those services relate to CMEs, and CBAY relates to our high fidelity wraparound service. We also support, along with our partner at Medicaid, the Department of Community Health, psychiatric residential treatment facilities, so PRTFs. We also have a role in crisis stabilization within the state. There are 4 CNA CSUs throughout the state, as well as some private hospitals that we work with. And then towards the bottom, that spans the continuum, you will find mobile crisis. You'll hear more about that shortly. Core services, our Center of Excellence for Children's Behavioral Health, housed at Georgia State. Some years back, we played a role in helping to create that center in relation to some research and fidelity monitoring. It worked out so well that we have continued to partner, and that center has grown by leaps and bounds. And then just training throughout the state. There's lots of trainings that we invest in, and so that spans the continuum. So the system of care framework in Georgia. So system of care is evolved. It was created about 30 years ago, so early 80s, early to mid 80s, and it has evolved over the years. And there's an official definition that SAMHSA, that lives with SAMHSA, on the system of care. And so if you take the elements as it relates to system of care, it's a spectrum of effective community-based services that is organized into a coordinated network, that it is family and youth guided, which also includes the family voice, and that is culturally and linguistically meets the needs of children and families. And so what that looks like in Georgia, in doing this work over the last year and a half, and talking through some of those discussions, it became clear that those that have been doing this work for a long time maybe had some assumptions as it related to, everyone's being on the same page, so to speak, as to what the system of care looked like in Georgia. And so we created this illustration to describe what that relationship looks like in Georgia. And so at the practice level, you have LIPTs. At the very top, you have the governor's office. And then you have components in between that I'll go into a little more here, and those two bidirectional arrows. And so ideally, as the system was developed, and it was developed with the idea in mind that practice would inform policy and vice versa. So as the system was working, it would reach out to the governor's office, and then those laws or policies would be passed that then would benefit the system overall. So what was represented on that previous slide at the level just below the governor's office was the Behavioral Health Coordinating Council, and that is memorialized in Georgia Code. That's the article there if you would like to do some additional research. Local interagency planning teams are also, you will find that in Georgia Code, and having a system of care state plan is also required by Georgia Code. And so the Behavioral Health Coordinating Council, the purpose and mission of the BHCC is to identify overlapping services regarding funding and policy issues within the behavioral health system. And so this web link here is on DBHCD's website. And so anything you want to know about the BHCC, you can find it on the department's website. Included there, you'll find names of council members, meeting dates, meeting minutes, and then also annual reports. And then in case you were wondering, well, who sits on the council? And so the chair is always the commissioner of the Department of Behavioral Health. And the vice chair currently is Commissioner Frank Berry, Department of Community Health, previous commissioner at DVHCD. And then also the secretary is, for those that knows him, Stan Jones, Esquire. He's the secretary, and he is also a family member of a consumer. Other commissioners that make up the council includes Community Affairs, Department of Juvenile Justice, Department of Labor, Department of Public Health, Corrections, Community Supervisions, Human Services, the State School Superintendent, Chairman of State Partners and Paroles. We have two elected officials, Representative Katie Dempsey and Senator Renee Unterman. The Disability Service Ombudsman. We have a parent representative, and additionally an adult consumer. And then next on that illustration that I showed is the interagency directors team. And the IDT essentially is a work group of the BHCC. It is not memorialized in Georgia Code, but it does the work of the BHCC. It includes a mix of state agencies and non-governmental organizations. And the focus of the IDT is to better child and adolescent behavioral health, to design and manage, facilitate, and implement an integrated approach, to implement the system of care model, to also inform policy and practice, and to share resources and funding. For additional information on the IDT, there's a web page that lives on the Georgia State Center of Excellence website. And there you can find the annual report, the Georgia System of Care brief that I'll refer to here shortly. Well, the a brief, but also the report. So I'll talk about the report. Members and the LIPT chair contact list. And just in case you're wondering, LIPTs, there are a lot of them in Georgia. So we have 159 counties, but we don't have a LIPT in every county, but we do have around 130 LIPTs. They are non-funded, and so individuals that have served as LIPT chairs, many have done it for a long time because they are caring and dedicated public servants or stakeholders in their various communities. And so we in my office and through the IDT have been looking at ways to be better connected to LIPTs and to support that work in those individuals. And so in case you're wondering about IDT membership, it includes the Child Service State Agency, so DBHDD, Community Health, Department of Early Care and Learning, the Department of Family and Children Services, DJJ, Education, Public Health, Georgia Vocational Rehabilitation Agency, Human Services. The partner organizations include all four of the CMOs, so America Group, WellCare, Peach State, and Care Source. Yes, if I don't do them in order, I get in trouble. Thank you. The Center of Excellence, the Center for Disability Leadership, also at Georgia State, CHOA, the Georgia Alliance for Therapeutic Services and Children and Families, the CSB Association of Georgia, Get Georgia Reading, Mental Health America Georgia, the Carter Center, Together Georgia, Voices for Georgia's Children, and the CDC is a consulting member. That body meets monthly and played a significant role in developing and implementing the current system of care plan for the state of Georgia. So here, this refers to the local interagency planning teams in the Georgia Code that mandates that work. What the code says there should be at least one LIPT per DBHDD region. DBHDD has 6 regions, but as I mentioned earlier, there are 130 or so LIPTs. So many more LIPTs than we have regions, and the need is there to have so many. The code says that permanent membership will include a representative from a local community health agency, so it could be a community service board, it could be a private provider that is enrolled with the DBHCD and licensed through Medicaid, DFACS, DJJ, Public Health, GVRA, and a special education staff member of a local educational agency. So many of the players that you've seen represented both at the high statewide level, at the commissioner level, chairman level, as well as the IDT level, and then on the local level. This lists the responsibilities of the LIPTs. Essentially, as communities coming together to coordinate services for those families, children and families, in order to help those children remain in the community by connecting them with the needed services and supports, or supporting them when they return to the community, say from a crisis stabilization unit or a PRTF. Or in some cases, if they're returning from a DJJ unlocked facility. So I covered a lot. So I wanted to show you this diagram again, just to reiterate that this is how the system was built and intended to work, and a lot of the work that we have done, both individually as agencies, but also as a collective body, is to strengthen and reinforce the system in Georgia so that practice and policy are complementary of one another. As I mentioned earlier, the System of Care State Plan is required and memorialized in Georgia Code, and really the plan provides a roadmap for children's behavioral health services in Georgia over the next 3 years. The code requires a 5-year plan, when the IDT started working on this maybe 2 years ago, the decision was made to create a 3-year plan because we anticipated a lot of change over the next year. We were operating in a dynamic healthcare environment, and so the group landed on passing or creating, I would say, a 3-year plan that then we would revisit what we learned each year around the July 1st, which is the start of the state fiscal year, to make any necessary changes to that. And then the BHCC approved the plan in August of 2017. The plan includes really 5 big buckets, which you can group as access, coordination, workforce development, funding and finance, and evaluation. And then the circle around those 5 buckets is continual evaluation, so continuously learning and adjusting, making the needed adjustments. I won't go through each of these, but there are 12 to 14 strategies for year one. So each year had, so again, it was a 3-year plan, and there were strategies and priorities for year 1, year 2, year 3. The bulk of those were in year 1, and a good amount also straddled between year 1 and year 2. The plan was completed, but not approved. We were maybe 3 months into the fiscal year when the plan was finally approved. And so we had to hurry up and play catch up if we wanted to make sure that we accomplish all of these in year 1. And so I'm happy to report that of the first year, all but 2, I think, were on track. And so, the group coming together and rolling up their sleeves have made great progress as it relates to access and coordination and funding and finance, and making recommendations for improving agency contracts that support system of care, and the like. And also, about the time that the plan was under consideration by the Behavioral Health Coordinating Council, the governor created, by executive order, the Commission on Children's Mental Health. So last summer, and that body met for several months and received both public and written comments from the public, and we were delighted, the IDT as well as the BHCC and Commissioner Judy Fitzgerald, to have this plan in hand to be able to submit to the governor's office for consideration. And many of the items that were submitted by the community and that were contained in the plan aligned. And so in December of last year, the commission released 8 recommendations. And the governor included funding for those 8 recommendations. Well, 7 of the 8 in his proposed budget. And the General Assembly has since passed the budget, funding all of those, 7 of those 8 recommendations that were brought forth. And so what those focused on is expanding the Georgia Apex program. And what that looks like, so it was included in that recommendation was $4.29 million. And so what that looks like in implementation, it allows us to expand the program by 13 awards. And what I should also say about these recommendations, DBHCD operates according to 3 tiers. And our providers are organized in Tier 1. That is what we consider our safety net. So community service boards make up our Tier 1 providers. Tier 2 providers are what we call community Medicaid providers, meaning that the bulk of their billings are made up of Medicaid billings. And then Tier 3, it's a little different on the adult side, but for my particular office, Tier 3 would be intensive family intervention providers, short for IFI. So these funds, in many cases, will support organizations that are enrolled in our provider network. So it'll be anchored to our provider network. Also including the recommendations was funding for supported employment, support education. In Georgia, currently, we have supported employment. It's a partnership between my office and adult mental health. It's a very rigid model, supported employment. And for young adults, we found and believe that they need flexibility, as we all once did, to be able to pursue both experience as well as higher education. And so these funds will allow us to explore that evidence-informed model here in the state of Georgia. It also, the funds include additional, allows us to include additional levels of support. So 10.4 million. What's included in that? We would like to release a RFP for crisis respite within the state. It is a needed service that's currently not available. It also allows us to enhance in our CNA CSUs, so by way of additional training and additional staff to be able to serve individuals that are duly diagnosed, so IDD, BH. It includes funds to support, one-time funds to support telemedicine infrastructure, and basically what that means is one-time funds for equipment to support our Apex providers that are serving children in schools, so allow them to be able to service in schools and communities equipment that supports that work, community-based services. The recommendation related to coordinated training was not funded. And so just a little context on that. There were some training opportunities that were put forth by the IDT, the community. As I understand it, there was spirited debate as it relates to the investment in trainings in Georgia and what additional trainings were needed. And so where the commission landed was to create a digest on trauma-informed care trainings in Georgia for over a period of time. There had been a lot of investment on the agency side and the private sector side. And the thought was that, and it also supports one of the recommendations of the System of Care State Plan, is for agencies to coordinate and maybe better pool those funds. And so if we had a robust offering of trauma-informed care trainings and ongoing training opportunities in that area, then maybe we could shift and support additional fundings that may be needed in the state. And so the department has supported that recommendation, moving it forward. We hope to have details of that in the next 2 weeks or so. Also included in the recommendations were to continual support and enhancement of high fidelity wraparound. What I will say there is that our wraparound program began as a demonstration waiver. It was funded through 3 different sources, 2 federal fund sources and 1 state fund source, and that work has evolved over time. And so to sustain that service has been added to the state Medicaid plan. And so these funds will allow for that transition and additional training for those providers throughout the state. And then the last 2, which will be led by our Office of Prevention, relate to combating the opioid crisis and suicide prevention training and some additional enhancement resources there. Wendy Farmer will speak later. I'm not sure if she'll touch that, but that work is in tandem with our ASO and our Office of Prevention. That completes my presentation. Please let me know if I can answer any questions you may have. Yes, ma'am.
Is all this funded?
All but, yes. All but the training inventory. Well, it's funded through my office, yes. So all of it has funding attached to it. Yes, ma'am.
These mental health clubhouses, how are they organized and who is eligible to join them?
So it's 15 throughout the state, and they're managed by our community mental health providers, and they primarily focus on those that are uninsured or SSI Medicaid, but also those that may have CMO Medicaid as well, and ideally. They provide a safe place for families to go to network and support one another. Non-traditional setup for the most part. What part of the state do you live in? Are you here in Metro Atlanta?
Stone Mountain.
In Stone Mountain. So we have two clubhouses that operate in the metro area. One by Chris 180. That clubhouse actually recently transitioned to what we call a peer drop-in center. Chris 180 is in East Atlanta. And what they were finding is that population that was making their way to the clubhouse would have been are better supported through that peer drop-in model, and couch surfing, homeless young adults, and so they were more supported by that model. And then Viewpoint Health is also a provider that operates in Gwinnett County. And I'm sorry, I'm forgetting. We have SEPA also operates one of our mental health clubhouses, and SEPA is a provider that prioritizes serving the Latin American population in Gwinnett.
Hi, I'm a core provider, and I'm trying to find out how can we get involved in the APEX program.
When you say you're a core provider, would that be? Would you be are you enrolled with DBHCD as a what we call a tier 2 provider? Okay. Well, the most of the services that will roll out through the commission's recommendations will be released by way of a statement of need, or for the crisis respite, a RFP. And so we expect that to come out any day now on the Apex, and then the other services will follow shortly thereafter. And so once that statement of need is released, I would encourage you to respond to that. It should be posted to our website. Also, you can connect with Layla Fitzgerald, who is the programmatic officer for both our mental health clubhouses and our Apex program. And so if for some reason you missed the official announcement, Layla can make sure that is circulated.
If that's all the questions we have, we're going to take a short break and we'll give you a heads up before the panel begins.
Thank you.
Start without you if you're not seated. So I have the great privilege of introducing the moderator for our panel discussion. This is Dr. Erica Fenner-Sitkoff. She's been with Voices for Georgia's Children since 2014, and she now serves as their executive director, leading them forward on a brilliant path. She has experience with a PhD in clinical psychology, and she's worked for a long time with mental health and development disabilities. So we're very honored to have her here and to have her leading our panel discussion today. Erica, please take it away.
All right. Good morning, everybody. Well, I feel honored to be able to be up here with the company of our panelists that do incredible work in our community. I'm going to do some brief introductions and then turn it over to them so you'll get an opportunity to hear directly from them, and then I'll open the panel to questions from the audience. So Wendy Farmer is the CEO of Behavioral Health Link, which operates the Georgia Crisis and Access Line. For those of you who don't know what GCAL is, you should, and I'm sure Laura will share information about it. It's a critical resource to families and youth across our state. She has more than 20 years of behavioral health experience, bringing that work to running the hotline, among other things, and she is also a licensed professional counselor. We have Monica McGannon, who's the clinical director of behavioral health for children, adolescents, and young adults for Fulton County. And she brings more than 29 years of experience in the field of mental health. including forensics, child and adolescents, refugees, substance abuse, and hospice. And she oversees Chris 180's contracted services. She's also, interestingly, been a volunteer at the American Red Cross for many years, which includes her going and supporting families that have had traumatic events from national disasters, from earthquakes in California to floods in Georgia. And on the end, we have Laura Lucas, who is the Young Child Wellness Partner for Project Launch, which you heard Dante mention some earlier today. And she works with the Department of Behavioral Health and Developmental Disabilities. And she's been there for more than 10 years, wearing different hats, including working on the Child Adolescent State Infrastructure and Children's Health Insurance Program Reauthorization Acts. She also serves as the maternal infant early childhood home visiting program administrator for DeKalb County, and has worked in the world of therapeutic foster care as well. So as you can tell, we have an impressive group of panelists here today, and I'm going to ask them to start out with giving a brief introduction about their organization and how their organization fits into the systems of care that we've been learning about this morning. And we'll start with Wendy.
Can you hear me okay? May have to use my mom voice. Oh, thank you. So Behavioral Health Link has had the privilege of operating the Georgia Crisis and Access Line for the last nearly 12 years. So the Georgia Crisis and Access Line is a single toll-free number that is statewide. We take between 800 and 1,000 phone calls a day from all over Georgia. We have licensed clinicians and care consultants who help people navigate the system. And we get many different types of calls, from somebody who's in the midst of a suicide crisis or somebody who's just calling to access care. They may have a neighbor or a friend that might be struggling and needs some information. So we get many different types of calls. Part of our responsibility, certainly, we want to help de-escalate a crisis on the phone if we can, and then connect people to resources as quickly as possible, as close to home as possible. We're responsible for being the single point of dispatch for all statewide mobile crisis teams that are funded by the Department of Behavioral Health and Developmental Disabilities. And we dispatch upwards of 1,200 mobile crisis calls a month. We also do kind of air traffic control people into open crisis beds across the state. So keeping in touch with providers constantly, trying to get people care as close to home as possible. And our goal is to help people before it's a crisis if we can, but certainly in the midst of a crisis, we want to avoid any sort of unnecessary law enforcement intervention, any unnecessary emergency room intervention. Let's try to help people while they're still, at their kitchen table if possible.
Good morning. Is it working? So we use BHL all the time. Chris 180 is been around about 35 years, and we just expanded to Fulton County. So we've taken over the 3 offices that are in Fulton County that used to serve children and adolescents and young adults, which is College Park, Adamsville, and North Annex are the 3 places. So we cover pretty much the whole county. We provide all the typical services that you would think, with the different types of therapy, groups, that kind of thing. But Chris 180 also offers group homes, which we have 6, 4 boys, 2 girls group homes. We have adoption homes, which are really cool. We're trying to keep kids together instead of breaking them up. What a concept, out of a family. And so when DFACS calls and says we have 3 kids, 4 kids, and a family, we will take them and put them into one of our homes, and they get to stay together as a family. And then we look for an adoptive family for those 3 to 4 kids. And we're doing great so far. We're at 100% as far as adopted families and no returns, so to speak. We also have Apex, which Dante talked about a little earlier, and Apex is doing extremely well. Our numbers are looking really good. We have about 16 schools, and of those 16 schools, I would say around 8 or 9 are Apex, approximately. They're both DeKalb and APS school system. We have joined with Georgia State to do research, so we will have hopefully statistics on the APEX schools. What we're doing is we're taking some money from APEX and we're training the teachers in trauma-informed care because we're a trauma-informed agency. And we're teaching the teachers in our APEX schools only because that's where we have money. And then the other schools where we just provide therapy, we're going to match up the outcomes of the children. So not only absenteeism and behavioral, but we're going to see how the teachers perform too. They're doing fantastic. The teachers are loving it. So that's a really, really good thing. And then lastly, we've been given a very small grant from the county commissioners, Fulton County commissioners, on text a tip. And what it is, it's a company out of California that has spread here. And I have 5 therapists, including myself, because I can't recruit therapists because you're on call 24 hours a day. Mm-hmm. It's a lot like BHL. We don't get 1,000 phone calls. We get probably 50, 60 texts a month. So it's slow at this point, but we just started. And what it is, it's 100% anonymous. We have no idea what child's calling us. We have no way to reach them back. So if they're suicidal, we can't get to them because of the anonymity. And they're doing that on purpose so that kids feel free to call. And we're getting some really cool phone calls, texts. A girlfriend of mine is pregnant. What should she do? Someone said they're bringing guns to school. What should we do? It's that kind of text that we're getting. Someone was suicidal. So the therapist on the other end, of course, we don't do therapy, okay, guys? You can't do therapy on the phone. But we give them lots of options and where they can go, and we'll even hook them up with providers. So someone from a North school had texted me, and they were having issues, and I looked up very quickly all the providers in the North area, and I gave them 3 to 4 of them and said, here you go. And if you don't know your insurance, talk to your mom, find out what your insurance is so that they can get help. That we will need funding for, Dante, down the road. It's very small funding. It's only $10,000. It's really cheap. Okay, thanks.
Hi, I'm Laura Lucas here to represent Project Launch. Launch stands for Linking Actions for Unmet Needs in Children's Health. And as Dante gave us a nice introduction, our population is actually younger than usually like a DBHDD would work with, is 0 to 8. And in general, we're trying to create an early childhood system of care. Our pilot site is Muskogee County, which many of you know is Columbus. And basically what we're trying to do is create an easy, accessible system for young kids, because as was mentioned earlier in the presentations, if we can catch kids younger, get the intervention in there, get families help that they need earlier before the age of 9 and on up, it's easier. It's also far more cost effective. So this is a SAMHSA grant, so this is federal funds. We're in year 4 of 5. So we're kind of wrapping it up, but what we're hoping to do is, in some of the work that we're doing, is building an infrastructure so the work will continue. Funding is always such a tough thing, especially with federal grants and things, but really when you're looking at system of care, a lot of times things don't cost money. It's a conversation. It's linking with partners. It's figuring out who in the room agrees on that early intervention works and getting them together as an advocacy group, educating parents, making sure that they are aware of the signs to look for in early childhood, that there could be some issues that are addressed before the diagnosis. Basically, and really our approach is a little bit different than I'm used to, being a former therapist. I've worked with kids that already had the diagnosis, right? But there's so much you can do before the diagnosis, right? So it's really a public health approach. It's all kids. So really what we're saying is that all kids need to be developmentally screened, and making sure not just behavioral health and mental health, but everything. It's all together. It's all one person, right? So all 5 domains: physical, social, cognitive, emotional, and behavioral. So some of the things that we're doing is we're doing the Ages and Stages questionnaire and some other screenings, but that's the main one. Advocating for those to happen in all kinds of different settings. So, for example, you take your baby, your toddler, to the doctor every 6 months or so to get a height and weight check. I mean, that's a pretty standard thing. Well, why aren't we checking in on her social and emotional milestones? And having a screener like the Ages and Stages questionnaire will do that. And you can kind of score in a sort of area of concern, or you can score in an area of this is a big issue. And there's things that you can do. There's all kinds of early intervention programs, but sometimes the problem is these problems are not identified until the child walks into the school, and sometimes not even then, right? So basically, we're trying to create this early childhood system of care where not only are kids identified early, but they have access to quality care earlier. So making sure that there's professional development for folks to treat younger children, so there's better access. We're looking at a lot of telemedicine type things that were discussed before, so people have access across the state. So I'll tell you more about it as we answer the questions, because there's a lot to talk about. But basically, we're trying to catch kids early, so before the diagnosis is made.
Great. So all that said, with that overview, what does success look like for young people in the system of care? And more specifically, what does adequate access to care look like, and what are the results?
So we get the opportunity to see this every day, and unfortunately we see when it doesn't happen the way that it should as well. But when it happens the way that we think it can, in the best of worlds, a child gets access to care before it's a crisis, while there's still enough time to get them engaged in care when it's still a positive experience for them. When I train clinicians, we talk a lot about the awesome responsibility of being that person who helps someone access care, and how you can make that a good experience for someone, or you can make it a traumatic experience for someone. So do you want to, someone's first experience with behavioral health care to be in the back of a police car on their way to a hospital, or do you want to send a caring professional to their home to try to de-escalate things and keep those lights and sirens from being at the front door? So when it happens well, kids are identified in time before there's a crisis at that level, and we can connect them to services to meet their needs. I think it's a lot easier for kids and families to get engaged in care when it's not forced upon them in the midst of a crisis. So we work really hard to try to connect people to care before it gets to that point. Unfortunately, not everybody gets that message and doesn't understand how to access care, and we would hope that it would be that way for everyone.
So we see a lot of victories, luckily, at CRIS 180. In the school system, we're seeing them. I'll give you a couple examples. We're seeing them in the group homes. When group home kids who have been jumped around from house to house to house to house to house, and we've got them now for 2-3 years sometimes, to see them graduate high school and then go to college is like huge party time. So that's wonderful to see that. In the schools, we get the most traumatized kids because they've made it through the tiers of the school, and then the school says we're done, we can't do anymore, so then they pass them to us. And we're seeing kids that were so traumatized by many, many different things suddenly start to sit in their seats, and not suddenly, it's taken a few months, if not more, sit in their seats. They don't have to be sent to the principal's office. They don't get suspended. That's wonderful. We had a mother come in probably about a month or so ago. She said, "What'd you do to my child?" And I was like, oh God, what did we do? And she said, he doesn't cuss at me anymore. He doesn't beat up his brother anymore. And he's not in trouble at school. So what did you do? And I said, This was a family affair. You participated. So I'm trying to have staff give mom as much power as they can possibly give so that mom knows this is her. This is not us. We're just a little vehicle to get you there. So there's lots of opportunities. Because CRIS 180 is trauma-informed, we're 100% trauma-informed, so every single therapist must be trained trauma-informed. So if we hire newbies, that are straight out of school, they have to go through some tremendous training. They have to read books that are this thick. We go through book studies, we go through worksheets. It's like they have to go back to college again, just so that we know that they're trauma informed, so that all the kids are getting trauma informed care, and so are the schools. And that's what's helping, that we're seeing, because a lot of kids are traumatized, if not all of them, in the schools.
Okay, so I talked earlier about screening and assessment. So when you think of screening and assessment, sometimes you think, well, I've got to go to like a community service board or something, a hospital, to get screened or assessed. So what Project Launch is trying to do is make screening and assessment part of the processes that children encounter in everyday life. You register for kindergarten, you have to fill out an ages and stages questionnaire in Muskogee County and 9 elementary schools. And through that, you'd be surprised how many kids score in that. They're more in the kind of area for concern area than like there's a definite problem. But those are problems that can grow if they're not addressed. And it's all voluntary, of course, but we've had some really great responses with that. And parents fill it out because they're trying to register their kid for school, and it's part of the paperwork. We're also doing screening and assessments in early education and care centers. So when you're taking your younger child before they're in school and doing paperwork to enroll them, you are also completing one of those. We haven't quite got to the point where it's in every early education center in Muskogee, but we're getting close where they're making it part of their registration packet. A lot of other places that we're working with that have young children are doing one if they have concerns or problems with the child. Then they're recommending to the parent that they fill out the screener, and then we're helping them with that. So it's sort of like a culture shift of, we have to check in on our children's social, emotional, behavioral health, just again, like we would with their physical health on a regular basis. And, we've had some really great responses from pediatricians. When I first started this work, I thought this is going to be really tough to get pediatricians on board to do these screenings because the reimbursement rate for the time to do that is pretty low. I could have not been more wrong. We have actually not dealt with that at all because the pediatricians are saying, thank you for giving me something easy that I can do, because these are problems that come up, but I don't have a way to test it, to measure it, and to clearly link them with services, which is the other piece, right? So you're doing more screening and assessments. Well, then what do you do with kids who have concerns? Sometimes the doctors, the physicians, they don't know where to send them, or there's just one provider they send everybody to, but that provider doesn't do younger children, or they don't have that type of service. So a lot of it is conversations and partnerships, making sure that the local pediatrician is aware that there's a community service board right down the street that provides a variety of services. And a lot of times for younger children, or can refer for younger providers for younger children. So we have been able to do 1,000 developmental screenings so far, and close to 200 of those children have been referred for services. So 200 kids that would not have been identified were referred for some type of services. Also, as part of kind of what we're doing to try to get kids to be successful, is we got to make sure the provider pool is out there, right? So we're doing some workforce development. We have trained over 250 professionals in various things, but I always like to emphasize that 23 of those mental health professionals were trained in trauma-focused CBT, cognitive behavioral therapy, which we know is very important, as we just talked about. So that's just been in Muskogee County, so that's in that region. So, families a lot of times talk about barriers of getting up here to Atlanta to access services. They can't always do that. So the treatment stops, the intervention stops. So again, trying to increase access for everybody. I think also whenever you're talking about systemic care, you can't leave the families out, right? They have to drive the services. They have to be the center of everything you do. So we've also done a lot of work with trying to strengthen parent knowledge about social, emotional, behavioral health milestones in young children. We've held 10 parent cafe sessions with 234 parents. And in those sessions, if you're familiar with the model, they talk about various things, but a lot of it, the parent cafes that we've done have been focused on child development, parent-child relationships, and really making connections for support. I mean, even just getting a bunch of parents in the room that have some issues with their child to talk to each other, there's that peer support. And, oh, did you know this center does this? I mean, it is so powerful to connect people, and that's a lot of the work that we have done. And also, one thing that we're trying to sustain is to keep these parents meeting even beyond the parent cafes, because we've made a lot of connections with peer support with them. We've had 89 families that we've referred for home visiting. Home visiting is another thing that we're looking at for our higher end young kids that need some more hands-on intervention. Home visiting has been shown as a very effective service. And I think once you're in the home, you can also, being a former in-home counselor, you can also figure out some other stuff that needs to be addressed. Also, when you're looking at young kids, you're really looking at parents, right? What do they need? What do they need to support the child in their home? And how do we help them parent this child? And a lot of times that's overlooked. Sometimes you're just treating the child if they're at school. Well, what about the parent, and what do they need, and what sort of support do they need? We have also done a lot of work with the younger children, language nutrition, really talking about talking to your baby. This program is Project Launch. The grantee is Department of Public Health, so they have huge, big programs, Talk to Me Baby, about how important it is to communicate with your child. So because we're kind of out there trying to do screening and assessments, we're also kind of just educating on the front end. Talk to your baby, hold your baby. Is there something where you don't feel attached to your baby? We've had a lot of maternal depression issues where we recognize that when we go to home visiting. Well, that's your issue, so let's get you help and let's connect you with services. So it really is sort of a systems approach for the young kids to make sure that the parents are getting the help they need, and that there's really multiple systems where kids can get screened and problems identified and services linked.
Great. You talked about what success looks like when they are able to access those services. What do you think are the biggest barriers or challenges that prevent children, youth, and families from getting access to the incredible services being offered through your programs? And those can be anything from larger systemic or policy challenges to more localized community and familial challenges. And if you know of any efforts underway to address those barriers or challenges, please share those as well.
I think one of the biggest barriers that we face is stigma, and I think that forums like this are such tremendous opportunities to start breaking that down. People aren't ashamed to say that they need to go see someone about their heart. There's still so much shame associated with behavioral health challenges, and certainly with things that many people experience, like suicidal thoughts. So certainly stigma is a significant barrier for people accessing care. The workforce is a barrier for all of us. There are counties in this state with no clinicians, and that is a huge barrier when people are trying to access care, because you want to strike while the iron's hot. Well, if someone's willing to get care, you want to get them there, but it's very hard if you don't have enough professionals to do that. And particularly when it comes to kids, not only do you need to be a clinician, but you need to be trained to deal with children and families. It's not the same as taking care of an adult. It's much more complex, and then there's the need for the trauma-informed care, and not everyone is trained. So that's certainly a barrier. And then on the family level, just your basic things. I mean, it's hard for any of us to make time to take your kid to the doctor. Well, then you have to go to a separate doctor for behavioral health challenges. And if you're having struggles with transportation, with finances, all of those things make it very, very difficult for a family. And then we have people who are, if you don't have a place to lay your head, a consistent place to lay your head, it's very hard to stay engaged in care, even if you've gotten there. So those are some significant challenges that I think we're all still facing, and they lead to people unfortunately accessing care when they're in a crisis instead of before it's at that level. it's not all bad news. I mean, I think there are some really great things out there. That mental health first aid is really trying to teach people that it's okay to talk about behavioral health issues. That's a very powerful tool that we have now to try to get people to be willing to say something if they're concerned about someone. Being willing as a provider, there are many providers over the years who are very squeamish about taking a third-party phone call. I'm worried about my neighbor, or I'm worried about so-and-so, and they'd say, well, have your neighbor call me. Well, we need to be a little more flexible than that, so we're trying to do those things. I don't care who you are. If you're someone 3 doors down you're concerned about, you can call me, and we'll try to figure out how to reach out to that person. So we want people that when they're willing to reach out to be ready to help access care for people. So it's not all bad news. I think there's some good things happening.
Wendy, you hit all mine. Thank you. That's okay. My biggest ones that we see is transportation. Yep. Even though we have MARTA, it could be 2-hour rides from the person's house to our center, and it might be an 8-mile trek because they have to get on 2 to 3 different buses. And I know MARTA's working on that, which would be great if they could figure that out to have more direct lines. But transportation's an issue. Also, where centers are located, and I know that there are in-home therapists, but centers are sometimes located in odd areas. We see people above 26 years old by contract, other than parents of teenagers we can see. So that's a barrier. That's a really big barrier, is that. And then also, without home, over your head, clothing, and food, who is going to go to therapy? I know I'd rather protect my kids and try to get them clothes and try to get them a roof over their head than take them to therapy, even though they need it. So that's a barrier, and we're coming across so much homelessness. It's really freaking me out how much homeless is going on. We opened up a center right smack in the middle of Vine City. Awesome place to go, by the way. If you guys ever want to visit, it's on Cameron Alexander Boulevard. You can just go and visit. But it's in the middle of Vine City. It's got the worst crime rate in the state. And we opened up a center there with a bunch of different partners. And we did not open for homelessness. We opened to provide services for children, adolescents, and young adults. And we've already served and housed 30 homeless families. That was not on our radar. But it was such a need. We're like, okay, let's shift a little bit and start providing homeless services. So we're doing that now, which we had no intentions of. So that's another issue.
So our biggest problem is we're grant funded, so the money runs out, right? But as I talked about, we're trying to work with that, with sustainability practices. But I know I'm here kind of talking about Muskogee County, but I think a lot of the things that we've learned and a lot of the things that we're doing there can really work across the state. So I think right now what we're trying to do is sort of translate the things that we've learned to be more applicable across the state, and sharing those things at venues like this to let people know that what we're doing. I think, specifically in Muskogee County, one problem that we had was getting into the school system. We have a wonderful program that Dante talked about, Apex, which is phenomenal, but a lot of schools aren't quite ready for that level of mental health provision in their school. So one of the things that we do is mental health consultation. So it's kind of like before you would actually get the treatment. It's a lot of coordination. It's a lot of helping teachers and parents identify, number one, always identify if there's an issue, and then linking them with services. And that it's been a really huge service in Muskogee County schools that people have really just embraced. But to actually get in the door and do it, it was tough. It took us 2 years. It was only a 5-year grant. It took us 2 years to just be able to work in the school. But I think what they've seen since we've gotten in the school is that it saves so much more instruction time, and it leads to less disruptions in class and all these wonderful things. If you have somebody who is a mental health provider, licensed mental health professional, in the school to make sure that these kids are getting assessed, identified for what they need, and just linking them. And when I say linking them, it's a warm handoff. So one of our barriers is also we're working with kids 0 to 8 here. If the child doesn't have a diagnosis, you can't necessarily bill for coordination, right? And I have found, like, through this program, that coordination piece has been so huge. Families are more likely to get services if they know the person who's referring them, if that person can call them back and check on them and say, is this service effective? Has this worked for you? What just that follow-up is so huge, but a lot of times that's not done because there's not a very clear way all the time to bill for it, right? So in grants like these, it's nice because you don't have to have a billing code for what you're doing. You do what the family needs. So we're really working hard to try to figure out how we can incorporate sort of that coordination piece and that warm handoff if a child is identified as having an issue, how to link them with the services, and then follow up and make sure it's effective. Again, a lot of times folks are referred to come up to Atlanta and get services, and then it's done. But if somebody's not troubleshooting the transportation issue, those services are never received. So if you have somebody there to help with that, I think that's huge. And then I would kind of echo the mental health stigma, especially when you have your little baby or your little toddler. And, a lot of times parents look at themselves and say, well, what am I not doing right as a parent? Why are they having tantrums all the time and crying, and I can't get them to stop? And sometimes they'll go to their pediatrician, and unfortunately sometimes the pediatrician doesn't know where to send them. They're looking at medical issues instead of a behavioral health issue. So a lot of it's education about the milestones for infants in early childhood range in sort of that behavioral mental health area, social emotional health. And in everybody's packet here, I think it's a good time to point out this. We have these little, to kind of, try to fight the stigma, these little handouts with this adorable child here and another bigger boy on the back that you can actually look, and on the green part, and it says 8 clues your child may be having trouble with social, emotional, or behavioral challenges. And they're just very easy statements that a parent can read and say, whoa, my kid is kind of having trouble with that. So then they can do a clickable, trying to be innovative here, and go to a website where they can obtain an assessment. And for those online, that is on bigdreamsgeorgia.org. So you can check that out online if you'd like. But things like this to kind of fight the stigma and kind of say it's okay if your child is having these clues, then you can get some help. You can get some further assessment. So those are some ways that we've tried to challenge, conquer the barriers.
So I don't know about the rest of you, but when people talk about how to fix or address these challenges in Georgia, I often hear we should really look and see what Connecticut's doing, or you should really look and see what California's got going on, or Massachusetts. And sometimes we'll even hear, you should really look at one of our neighbors, like South Carolina, which we sometimes hear too. And I think that that's really important, that we should learn from lessons learned from others. But I have to say, there's some pretty amazing work happening here in Georgia right now, and you're hearing some of that up here. And I'm going to ask the panelists to share what they consider one of the most exciting things or innovative things that are happening right now to improve the Georgia systems of care. And it's also a great opportunity, and some of you have touched on this a little bit, that if they're not currently funded or there isn't a mechanism to sustain it, it's a great opportunity for us to hear all today what are some of those levers that we would be looking to continue to invest in and pull to address some of the challenges we're hearing.
So I think mobile crisis, Dante touched on this a little bit, but mobile crisis is one of those services that I think really, because it's available statewide, which is unusual, most states don't have that availability. really can help reach out to people before it gets, even though a lot of the folks that we see in mobile crisis are in crisis, some of them are just at that kind of urgent level where they, need care in the next couple of days. And having someone, a caring professional, go out to their house, even if it's in the middle of the night, and sit at the kitchen table and talk to someone can have a really powerful impact on a family. People ask, we do a lot of mobile crisis, and people ask us, why would you want to do that? Isn't that scary? You're going into some unknown place in the middle of the night. Our clinicians come back and tell us that those families and loved ones are so relieved to have somebody who's willing to do that in the middle of the night, go anywhere. But that's a real powerful entrance to care for people, that someone can come out to the home, and certainly not all states have that. So, when I go to national conferences about crisis, we're kind of looked at as a model for that. Even though, sometimes there isn't enough of it, and sometimes it takes a while, and there are a lot of people to be seen, it really can help people get access to care. Other exciting things, Dante touched on a little bit, that they'll be trying to increase the capacity of the crisis line to respond to more people. Many people don't know that if you dial 1-800-273-TALK, which is the National Suicide Prevention Lifeline, or 1-800-SUICIDE, if you dial that with a Georgia phone number, there are times of the day where you actually get GCAL, so we answer both lines. But right now we're only able to do that 8 hours a day. We certainly answer the GCAL number 24/7, but we're only able to answer those national lines part of the time. So we're going to be working on expanding our ability to answer more of those phone calls, so that no matter what number you call, you'll get the same kind of response. So we're excited about that. And then further down the line, we're looking at getting more ability to respond to people via kids, specifically via text and chat eventually.
This is not to be negative about the work that you do, because 95% of it is amazing, but as somebody who's called the GCAL line multiple times, and the last time my son had a crisis, I didn't call because the problem was that, knowing from experience, what happens is, a mobile crisis person will show up in 1 to 2 hours, and then, I'll do a lot of intake stuff with them, and then they'll offer me resources, which I pretty much already know about, and by that time, either the crisis has passed or the police are there, so that to me, I think there needs to be a separate category for GCAL for people who are just in super crisis, and they want somebody to be there like right now, so they don't have to call the police because they're worried about the police coming and shooting their kid or their relative. I know that just happened 2 weeks ago to a Somali American woman. Her parents, had called the police and they just shot her. They shot the woman, and I think that's all of us parents. That's our nightmare. You call the police just because you need to get an ambulance to take your child to the hospital, but instead something goes wrong and the police end up shooting your kid. So in that respect, I know that it's very difficult to work in that kind of system where you have to involve the police in order to get an ambulance, but there has to be some other solution to that kind of like instant crisis. What do we do without calling the police? How do I get my kid into a situation where they're not going to harm themselves or somebody else?
Exactly. I definitely can see where you're coming from. I mean, mobile crisis is not designed to be there in 5 minutes, unfortunately, and that's something we run into. And even we run into the situation where the police can't use mobile crisis, or they don't want to wait for mobile crisis to get there. So, some of that goes back to police training. Can we get more CIT officers out there so that if the police have to respond, could it be someone trained in behavioral health? But yeah, there's definitely a capacity issue there.
I'm going to ask to hold questions for just a moment and let the rest of our panelists answer, and then I'm going to open the floor up.
So I had briefly mentioned App Promise. It's incredibly exciting what's happening. If you guys don't know the zones for the Atlanta Police Department, Zone 1 is Vine City area, which is the most dangerous. Zone 2 goes a little bit further southwest, and then Zone 3, which is the next most dangerous area, is Mechanicsville and Peoplestown, that area. And so Chris 180 is real passionate about serving people that are underserved. We really don't want to work, forgive me if anyone lives in Dunwoody or Alpharetta, but we don't want to work there. We want to work where folks don't have anything and need help. So we thought outside the box because the state works so hard at trying to help serve everybody, and they can't serve everybody. So we partnered with a bizarre bunch of people. So we are with the Atlanta Police Foundation, we're with the Boys and Girls Club, Street Smart, and us. The four of us are in the At Promise Center. And we really reached outside the box and went after all the rich people. So we have the Hawks, who donated the basketball court, and we have the Blank Foundation, who I think owns half of Atlanta. They donated the building, so they had the building refurbished, which was an old school. And then the Boys and Girls Club, of course. And so we have a very eclectic group in there. It's not all mental health, and there's hardly any physical health because there is a FQHC about half a mile away. And it's working. It's actually working. I mentioned Street Smart is in there also. They work with the CSEC population. And so now the Blank Foundation is very impressed, and they're like, well, let's open up a second At Promise. So now they're looking at opening up a second one in the Zone 3 area, and we're hoping to have it spread throughout the really tough areas in Atlanta so that we can serve all these people that aren't getting served. Most of them are uninsured for the most part. Some of the kids have insurance. And we've been called by 2 other states to say, hey, tell us how you're doing this. How's this working? Because we want to do this here. So we do have some good things that are popping up in other states. That's what's happening.
I wanted to also say for in Columbus, the police department is involved in our project, and we went after them specifically because we wanted them to be involved, and they were very interested. And I think, not to generalize too much, but I think a lot of police departments would be interested in training, behavioral health training, and learning more about how to de-escalate in a nonviolent fashion. So I just wanted to mention that we are looking at that aspect of partners. For our sort of innovative project, it's again, we're working with little kids, so it's a little bit different, but we really tried to think about how can we educate a large group of people about the importance of social emotional health. And one thing that pretty much everybody agrees with that you can do with your child that's a positive thing is reading, right? Literacy. So what we did is we held a Let's Read Muskogee event, and the first year we did it, we distributed about 2,000 books, and in the 2,000 books, our little flyers were in there, kind of educating about social emotional health, and the books were also age appropriate books about social emotional health. Like I think one of them was called Sophie Gets Angry. So. Talking to little kids about emotions, and it's okay to feel angry, and what do you do with that, and who do you go to, and how do you deal with that. So we had a lot of community members come out and read those books in various locations across the county, and then each child got to take that book home to their parent with our flyer and information. That event was so popular the first year that we did it, that we had people calling us saying, when are you going to do this again? I want to read. I want this at my child's school. My neighbor got this book, and I want one for my child. So this year we did it, and we do it around Dr. Seuss's birthday. So we're promoting literacy. And it was a huge thing. In fact, we just did it one day the first year, and this year it was like 4 or 5 different events in the month of March. So we did the same thing. Reading social emotional appropriate age appropriate books, putting our flyers and things to get out to homes, and by the way, that's in Head Start, early education and care centers, Fort Benning, which is also located in the Columbus area. We did it at some of their hospitals and other events, the library. So when I say like across the county, we tried to get it, pretty much anybody who wanted to read to a group of young children, we got them to do it. But we also got a proclamation from the mayor of Let's Read Muskogee Day, with some leadership sort of recognition of the importance. We did a literacy forum at Columbus State University where we invited professionals and students to come learn about the importance of literacy. And let me be clear, we didn't just talk about literacy. We talked about how literacy is a vehicle to promote social emotional health in your child. It's a way to attach, it's a way to help them express emotions. So there was a lot of interest around that, a lot of news coverage and things like that. So we were able to distribute 4,000 books this year. And I would say sort of I don't know how innovative it is, but it's sort of the system of care, sort of common sense, is that we made a lot of partners in the community with this event. Because sometimes it's easier to get behind literacy than it is like mental health. Mm-hmm. But if you use that as a vehicle and start talking about mental health while you're talking about literacy and giving books that are about mental health, people get on board. They love it. We had a big birthday, Dr. Seuss birthday party at the public library that was well attended. We also did a book fair parade, and that wasn't even our thing. Somebody came to us, the housing authority came to us and said, we heard you're doing this, we want to be a part of it. We have this book parade every year where we go give books to everybody that's living in one of the housing authority places. So we partnered with them, and it didn't cost us a thing. They had already had money for this and the books and things, so we just added our marketing materials and went on. So we partnered with the Literary Alliance. We didn't provide all the books. They provided most of them because that's what they do. Again, public library and quality rated early education and care centers also kind of helped us. So it was a community event, and it was really the community coming together for these kind of things. So I think sometimes you think innovative, you think technology, and yes, that's true, and we're trying to do some things with that too. But a lot of times it's just talking to your community partners and coming up with common ground, and kind of, again, that holistic approach of addressing mental health along with physical health and all the other things, literacy, that need to be addressed.
Thank you. Okay, we'll open the floor up to discussion. Anne?
Yeah.
And I wanted to know what, if anything, was underway to keep going and scale it out,
Mm-hmm.
or if that's something that needs to go to the General Assembly to look at funding.
Well, thank you. I would love it to go to the General Assembly. Okay, so we're trying to we have a year and a half left. So what we are trying to do is, it's like some of the things I just talked about, it doesn't cost money. It's getting people together under sort of the auspices of early intervention. There's lots of people in communities who are already doing early intervention. Let's link them with the libraries. Let's link them with the literacy initiatives or the housing authority, and do book parades and things, and put education about social emotional growth. So a lot of it, and that's why sort of the name of it is linking, because you're linking partners. So let me reiterate, a lot of times a part of a system of care is just linking people and talking with each other about this. However, it's really good to have staff people who can do all of that. So we are trying to, in Muskogee County, sustain things such as adding those developmental screenings into processes that already exist, like enrollment for kindergarten or pre-K. And hopefully that will last beyond that. Now, that's going to take a commitment from the school to get, you can do that particular screener, the Ages and Stages questionnaire, you can do online, and it'll screen it for you. So it's an investment in the technology to do that, and then the person to, look at that, and then hopefully we're going to sustain our mental health consultant who works in the schools, who does the results and then links the parents with the warm handoff. So do I have any concrete, sustainability funding? No, we do not. But we're trying to do things that are incorporating some of these things in processes that already exist, and educating people on the importance of not leaving social and emotional and behavioral health out of the picture. There are pediatricians in Muskogee County who will keep doing the ASQ. In fact, they're doing it, nurses are giving, administering the tool. All we're doing is picking up the results and then referring the family. So we're talking with them about who on your staff can help with this, who can do that coordination piece that you can't bill for because the kid is 3 and doesn't have a diagnosis yet. Also, the grant is kind of housed or whatever with public health, who does have a lot of wonderful programs. So we're looking at ways to incorporate some of the things that we've learned with programs that they're working on too. So I guess to say, what I would say to that is to be continued. I think part of our mission or goal is to put all of this in a 1-pager paper, whatever, although I think it would be 2 or 3 pager, but about our learnings and sharing it across the state. And that's some of the things that we are doing. Let me give a shameless plug here. We are presenting at the System of Care Academy, I think June 22nd. Well, 22nd is the day that we're presenting. So I know registration is coming out for that soon. So if you want to learn more about Project Launch, and one of the things that we're trying to do in that session is educate things that we have learned about and how you can replicate those in your community. We are presenting there. So we're trying to share what we've learned, and then also trying to figure out how to sustain some of the actual tangible positions and things that need to be sustained to continue the work.
And Laura identified a key issue of the concern that you have to have a DSM diagnosis in order to receive reimbursable services. And that is not necessarily good clinical practice to diagnose a 2-year-old with a mental illness, because they're still developing, but they need critical services. And there are several of us in collaboration with Project Launch Leadership, Decal, Voices, Gears, to try and identify what does that process look like that we could possibly be able to bill Medicaid and get reimbursed for those services, that we could sustain some of that consultation, because screening can be very powerful, but if you don't have the ability to do a warm handoff, you can actually get a backlash to being worse off, candidly, than you were before, because there's an ethical obligation of those that are screening to be able to do something with that information. So it's been incredible to see and learn from Ms. Gogi, and the power of having that knowledge and early on to be able to direct kids to services, but then also having that resource available to direct them to. And so we're working on that. Would be a great area, and to follow up with, of what that looks like through funding and our Medicaid state plan. Other questions or comments? Yes.
And Laura, you've been good about talking about how you're going to try to sustain some of the pieces of Project Launch and what you've learned. At the same time, what would you say are the key elements of Project Launch that need to be sustained? So, for example, sorry, I mentioned Determinant here. We took a group to Columbus to meet with Project Launch, and they were like, "This is great. We didn't, we wish that we had connected to the same resources." Some kind of anchor. It's fine to say so and so needs to connect to a library, but if, as you said, if there's not a person to help them, so what are the key elements, and what does that cost?
Right. I think initially it has to start with the screening, because you have to make it acceptable and kind of integrate that practice into the community so you can identify the kids. Secondly, just as we were just talking about, once you screen and identify that there's a kid with a problem, you have to have a place to send them. And then it comes in, well, how much is this going to cost me? Does my insurance pay for this? All that is very gray. And a lot of times parents stop right there. Okay, there's a problem with my kid, but I don't know how to get services. I don't know how to deal with insurance, all of that kind of stuff. So that's where that coordination piece comes in, and that's what I was saying earlier. You can't bill for that. The kid hasn't even been diagnosed, and so it's very difficult, that area right there. So I would say that's sort of the anchor, sort of that coordination piece that you can't bill for. Because a lot of times what you find is the child is exhibiting symptoms that are of concern because mom has mental, health or maternal depression or a mental health issue or substance abuse issue that has not been identified. So you can bill for those services, right? But it takes someone doing the work, getting in there and figuring it out. And a lot of times with these assessments, we will send one of our project launch staff to the home, of course, if the parent wants that and is okay with that. And once you're in that environment, you're seeing what the child is growing up in and able to really take a holistic approach to addressing all of those issues. So I would say that to me, you got to have the initial screening, but it's that coordination piece that I think most people have been so grateful for because that's what's missing in the other parts of the system. There's a lot of places where you can get an intake assessment or whatever, but if you know to do that, right? So then once you do that, it's like, well, where do I go from here? They told me to go to this place, but they didn't answer the phone, or they said I had to have insurance. So then there's this child identified with this issue, and then also think about how the parent feels about that now. Now you know something's going on with your child, and you don't know how to address it. So that's more stress and all that kind of stuff. So I would say that kind of coordination piece, and see, and that piece is so tricky because you have to have a staff member to do that. But a lot of times, like what we're trying to do with the school is connect them with the community service board so that the school feels like they know what the community service board can offer and who they're sending, having one person at the school who's not Project Launch, sending somebody, at the community, sending the family to somebody at the community service board and then following up with them. But people are busy. They have so many things to do. It falls off the plate, and that's how, unfortunately, sometimes these things fall through the cracks. So I guess, yeah, that coordination piece is huge.
Yes.
Are there enough providers once you find you identify a child and you're able to coordinate?
No, not always. It depends on the issue. A lot of people aren't aware of what programs are out there. There's an awful lot of programs, even I've learned, because I'm a DBHDD person, but I've learned all kinds of stuff public health does that I was not aware of, especially for younger children. So a lot of it's sort of knowledge. It's out there, but then it's like, how do you, get to it? Is it accessible for the person? I think if you live in Metro Atlanta, there's a program somewhere for you. You just got to figure out how to connect to it. But for Muskogee County, a lot of times there are some rural parts of the county, and a lot of times there's just not the providers needed. So some of the things that we're trying to do with public health is partner with the local hospital to do some behavioral health telemedicine work. And some of the providers are already doing a little bit of that, but there's such restrictions. It's only from this to this and this kind of insurance and all this kind of stuff. So right now we're trying to kind of work to kind of alleviate some of those barriers, but it is challenging. That's, like I said, we've done a lot of training too. And before we did the training on the trauma-focused cognitive behavioral therapy, that was not really an accessible thing in Muskogee County. I think there were some, but not a whole lot. So I think always looking at your workforce. There's also a lot of programs I've heard about where people are trying to get mental health professionals to go to more rural areas, universities and things like that. So I think it's a partnership across the board. It's with, Columbus State University is somebody that we're partnered with and talking a lot with about, hey, let's stay in this area and provide, high-level mental health treatment for young children. Because you're right, there's limited providers. So that is a problem. Yes.
Other questions? Okay. So I have a question. So it was talked about earlier, the investment that was made following the governor's Children's Mental Health Commission and the legislature forwarding on with that with increased dollars towards children's mental health. But we're going to have a new governor starting next year. What would be your ask of the new administration to make sure either they kept doing or started doing? And anybody can take that.
I can speak to that. I don't know how many years ago, it wasn't that long ago, I think it was Department of Juvenile Justice, for somehow they had the power to end substance abuse treatment for teenagers. So there's not anything out there other than private, of course. So for uninsured folks, we don't have any place to send them for IOP programs, intensive outpatient, sorry. Not inpatient, but outpatient, to keep them in the community. So we really need some money devoted towards IOP programs for teenagers.
I think a lot of effort needs to be put into bolstering the workforce here in Georgia to help care for these kids. The universities, it's hard to find a clinician that's willing to work at 3 in the morning. And how can we make that kind of career choice reinforcing for people? How do we attract good people who want to do that kind of work? If you can go work 9 to 5, it's a little easier to do that. So how do we support, maybe through loan forgiveness or something, for clinicians to really decide they want to do this kind of work, because it's not a 9 to 5 job.
I think I've already answered this a little bit, but I would just kind of add to that I used to work with adolescents in home, trying to keeping them retained in the community, and some adolescents that went away for residential and treatment, and then they're coming back into their community, and it's hard. It's hard on the parents. It's hard on the kid. It's just hard. So I don't think that there's anybody that would argue that if you could have had a chance to work with that mother and that child, 5-10 years before that point, what could you have done? And I think for me, that's what Project Launch kind of gives you an opportunity to look at. And I think, I know there's already money and investment in early intervention and education, but sometimes I think it's so siloed, and again, I think just taking more of a system of care approach with that, and really getting the police department involved, and getting the housing authority, and just folks that business folks. We have in Columbus, we have our Chamber of Commerce involved, so they're writing their business plan for, it's called Columbus 2025, and we got in that business plan to make sure that kids are ready for school. And so with that's screening, that's assessment, that's linking them to services, that's making sure that we have workforce training. So I think, to me, just investing in early education, in intervention, in a smart way, requiring community partners to come together and kind of use system of care sort of philosophy to work forward with that. This is the first time DBHDD and public health have partnered on a federal grant, and that's kind of amazing to me. And we have done so much work together, and sometimes you think, well, DBHDD is over here, the kids that have diagnoses and behavioral health issues, and public health's like everybody. Well, there's a lot of crossover there, and I've learned an awful lot just working within that department. So I think, again, we, system of care stuff, let's work together in the same sandbox, and I think if that's more part of the funding mechanism, sometimes that will help people make connections.
My last question for the panel is, what is your ask of the rest of us here today to help you with your efforts and to take it further?
I think just to make sure people know about the resource, get the word out, let folks know that it exists, and help us find other people who want to do the work. If you know people who have a passion for that kind of work, we always need people to do it.
Great.
I come from serve the underserved. That's just where I come from. I'm a social worker. I was at 3 years old, according to my mother. So I'm all about serving the uninsured because they don't get good care for the most part. They're thrown around. They don't know how to speak up for themselves for the most part. So to be able to serve those that don't get good service is, I mean, that's just a ticket straight upstairs when it's over, if you ask me.
I would just say, again, kind of that holistic approach. If a child is identified with a heart murmur or something when they're very young, there's services that are wrapped around that child throughout his or her life to make sure that that's monitored, that, insurance stuff is worked out so that they can get the care they need, so that they can have what they need in school if there's a problem. Well, why don't we do the same thing with mental health issues or social emotional issues or developmental disability? We've kind of sliced everybody up into these domains when really it's the whole body, right, that we have to focus on. So I just think it's a paradigm shift, really, just for whenever you're advocating on the platform that you're advocating for, just think about it in the holistic way. Like, what are the child's physical needs, mental health needs, behavioral health needs, social emotional needs, cognitive needs.
Great. Everyone can join me in thanking our panelists today. Thank you all for being here. I think am I going to turn it over to Alyssa? Okay. Thank you all for being here and participating, and I'm going to turn it over to Alyssa.
Hi, folks. I want to thank our moderator, our panelists, and our presenters for being here today with us to talk to us about children's behavioral health in Georgia, and also to thank all you for coming out to learn more. GHF is actually going to be producing another paper on children's health in the next few months. So if you think that's something you'll be interested in, please write the best mailing address you have for yourself on the back of the evaluation forms. Those are in your yellow folders on the left-hand side in the very back. And after you filled out the form in its entirety, please hang on to it. Feel free to grab a box lunch from over here in the corner and just leave the evaluation form on the registration desk on your way out. I, along with other JH staff, will be here available to answer any questions you might have. But thank you so much for coming out, and I hope you'll have a wonderful day. It's so good to meet you, too. I had to put a face in it.